أعزائي طلبة المرحلة الخامسة. Our presentation today is about disease of bone. We will talk about two problems, two most important conditions related to bone disease. First one is osteoporosis. The objectives of this presentation are to define and classify osteoporosis, to know its prevalence and its burden on the community, and to understand some aspects of its pathogenesis, its causes, and associated risk factors, and to identify clinical features, diagnosis, prevention, and treatment of this condition. First, we'll begin with definition. WHO defined osteoporosis as a disease. So it is defined as a disease and not an aging process alone. It's characterized by low bone mass and microarchitectural deterioration of bone tissue. This will lead to enhanced bone fragility and increased risk of fracture. There are many factors that contribute to bone resistance and fracture other than bone mineral density. What we measure actually in daily practice to diagnose osteoporosis is the bone mineral density. Other factors which can affect the strength of bone is the bone quality. The bone quality, till now, we cannot measure it. The NIH, National Institutes of Health, redefined osteoporosis as a disease of compromised bone strength, with bone strength made up of two components, bone mass and bone quality, that result in increased risk of fracture. This figure shows the vertebrae, the cross-section of this vertebrae. The above one is the normal bone. The below one is a bone with osteoporosis. As we see, there's thinning of the trabeculae. There is increased porosis between trabeculae. That's why we called it osteo related to bone and porosis. Osteoporosis. This is the same section. Compare normal bone with osteoporosis. The prevalence of osteoporosis is increasing with age. In USA, the prevalence of osteopenia, which decreases in bone density, is 15 million in women and 3 million in men, while the osteoporosis prevalence is 8 million in women and 2 million in men. A fracture related to osteoporosis affects 30% of women and 12% of men at some point in their lives in developed countries. In UK, fractures are sustained by over 250,000 individuals annually. Most common sites of osteoporotic fractures are forearm, spine, and hip. Hip fractures associated with immediate mortality of 12% and continued mortality of 20%. This X-ray shows the classical site for Colles fracture. This is the many compressed vertebral fractures. This X-ray also shows the worst fracture with fractured neck of femur. Few points about pathogenesis of osteoporosis. The underlying mechanism of osteoporosis is imbalance between bone formation and bone resorption. Normally, there is a constant matrix remodeling of bone. There's a continuous process. The bone is a live tissue. Continuous process of bone destruction and bone formation. Up to 10% of all bone mass undergoing remodeling at any time, at any point in time. The cells which are responsible for bone resorption is osteoclast, which derived from bone marrow. And those cells who are responsible for bone formation is called osteoblast. This process affected by many factors. First of all is hormonal factors. Lack of estrogen to menopause, increased bone resorption, and decrease the deposition of new bone that normally takes place in weight-bearing bones. The alpha form of estrogen receptor appeared to be the most important in regulating bone turnover. In addition to estrogen, calcium metabolism plays a significant role in bone turnover. Calcium and vitamin deficiency leads to impaired bone disposition. In addition, parathyroid gland react to low calcium levels and secrete parathyroid hormone, which increase bone resorption. Another mechanism is the activation of osteoclasts. We have a molecule called a truncal receptor activator for nuclear factor ligand. This molecule is produced by osteoblasts and other cells like lymphocytes and stimulate rank, which is a receptor activator of a nuclear factor. On opposite side, we have osteoprotein, which binds to rankle before it has an opportunity to bind to rank and suppress its ability to increase bone resorption. These factors are closely related to tumor necrosis factor. We have two types of bone, trabecular bone and cortical bone. The trabecular bone, or also called cancellous bone, is a sponge-like bone present at the ends of long bones and vertebrae, while the cortical bone is a harder bone. It constitutes the outer shell of bones and the middle of long bones, shaft of long bones. Because osteoblasts and osteoclasts inhabit the surface of bones, so trabecular bone is more active and more subject to bone turnover and to remodeling. And we have some tool to measure the trabecular bone in patients' body skeleton. Common osteoporotic fracture sites, as we said previously, is the wrist, the hip, and the spine, because they have a high trabecular bone. Around the age of 30 to 35, trabecular bone loss begins. Women may lose as much as 50%, while men lose about 30%. Classification of osteoporosis. Osteoporosis classified into primary and secondary. In primary, we have two types: menopausal osteoporosis and age-related osteoporosis. The menopausal osteoporosis occurs in persons at ages of 51 to 75. It is 6 times more common in women than men, associated mainly with Colles and vertebral fractures. The age-related type 2 osteoporosis is present in the age of more than 60. It is 2 times more common in women, associated with vertebral and hip fractures. Primary osteoporosis related to sex hormones, changes in sex hormone that occur with age. The secondary osteoporosis may be due to many causes. We have risk factors for osteoporosis: non-modifiable and modifiable risk factors. The non-modifiable are female gender, thin, small bone frame, family history of older family members with broken bones, early menopause due to less exposure to estrogen, Caucasian and Asian race, and of course, the age. Modifiable risk factors include vitamin deficiency, smoking, excess alcohol, malnutrition, being underweight and inactive, consumption of high-protein diet, endurance training, excessive caffeine, and soft drinks. Secondary osteoporosis can be caused by many diseases and disorders like hypogonadal states, endocrine disorders, pregnancy and lactation, malnutrition and malabsorption, rheumatological disorders renal insufficiency, hematologic diseases, inherited disorders, rare inherited disorders, and certain medications. One of the most important medication, which is commonly used drug, is corticosteroid, which can lead to osteoporosis when given a dose exceeds 7.5 milligram of prednisolone daily and continued for more than 3 months. The pathogenesis of steroid-induced osteoporosis is related to osteoblast dysfunction and steroid-induced osteoblast and osteocyte apoptosis. Steroids inhibit intestinal calcium absorption and cause renal leak of calcium. Also, high-dose steroids for a long period can cause hypogonadism. Other medications which may cause osteoporosis: barbiturates, phenytoin, anticonvulsants, thyroxine over replacement in patients with hypothyroidism. Several drugs include induce hypogonadism, like aromatase inhibitors used in breast cancer. Anticoagulants long-term of heparin and warfarin also lead to osteoporosis. Osteoporosis in men is less common. Secondary causes identified in 50% of patients. The most three common causes are hypogonadism, steroid use, and alcoholism. The main clinical features of osteoporosis. Actually, osteoporosis is a silent disease unless the development of fracture. Progressive break in person's back causes the person to lose height, sometimes even without pain. Spinal compression causes a gradual decrease in height due to forward bending of the upper spine, increased kyphosis. And this will lead to prominent abdomen. This is the kyphosis in patients with osteoporosis and compressed vertebrae. How we diagnose osteoporosis? Actual diagnosis of osteoporosis till now depends on measurement of bone mineral density through use of certain machines called DEXA, dual energy X-ray absorptiometry. Also, we should investigate patients with osteoporosis to detect underlying cause, secondary causes mentioned previously. What about X-ray, role of X-ray in diagnosis of osteoporosis? For detecting complications of osteopenia such as fractures, second, for differential diagnosis of osteopenia, and for follow-up examination in specific clinical settings like soft tissue calcifications, secondary hyperthyroidism, or osteomalacia, renal osteodystrophy. Actually, the X-ray, plain X-ray, is insensitive method for diagnosis of osteoporosis. 1/3 of the bone should be lost before the appearance of osteopenia on X-ray. The main X-ray features of generalized osteoporosis are cortical thinning and increased radiolucency. Frequent complications of osteoporosis can be detected by X-ray easily due to vertebral fractures. DEXA is the gold standard method for diagnosis of osteoporosis. Osteoporosis diagnosed when the bone mineral density is less than or equal to 2.5 standard deviations below that of a young adult reference population. This is transferred as a T-score. WHO established the following diagnostic guidelines. When the T-score -1 or greater, this is normal bone. Between -1 and -2.5, we call it osteopenia, and -2.5 or above is osteoporosis. When there has been osteoporotic fracture, we call it low trauma fracture or fragility fracture, defined as one that occurs as a result of a fall from a standing height. The term severe osteoporosis is used. For osteoporosis in men less than 50 years of age and the premenopausal women, Z-scores are used, which compare with age group rather than peak bone mass. This is the DEXA machine for measurement of hip and spine bone mineral density. This is the figures which are obtained through this machine. How we prevent osteoporosis? Methods to prevent osteoporosis include changes of lifestyle. However, there are medications that can be used for prevention as well. Another important concept is the use of orthosis, which help to prevent spinal fractures and support the building up of muscles. Fall prevention is an important component of prevention. The change in lifestyle include smoking cessation, moderation of alcohol intake, exercise and proper nutrition, jogging, walking, or stair climbing is important, training for balance, gait, and reduction in risk of falls. Nutrition, of course, we should take a sufficient amount of calcium and vitamin in diet. People at risk of osteoporosis, for example, steroid use, are treated with vitamin D and calcium supplements, and often with bisphosphonates. Vitamin D supplementation alone does not prevent fractures and need to be combined with calcium. Recommendations for calcium intake is 1,200 milligrams per day. This is the food which are rich with calcium. The medications used for prevention include bisphosphonate, used in cases of very high risk. Other medicines prescribed for prevention include lecture4, which is a selective estrogen receptor modulator, estrogen replacement therapy in perimenopausal period, testosterone, and hypogonadal men. Treatment of osteoporosis. Actually, there are several medications used to treat osteoporosis. The medications can be classified into anti-resorptive or anabolic. Those who prevent destruction of bone, resorption of bone, and those who build bone, new bone. A major problem is gaining long-term adherence to therapy from patients with osteoporosis, as we are dealing with silent and chronic problem. Anti-resorptive agents, first-line treatment of osteoporosis, bisphosphonates. They are the main pharmacological measures for treatment. Bisphosphonate drugs are first-line treatment in women. Most often prescribed are sodium alendronate, 70 milligram once a week, risdronate, 35 milligram once a week, or ibandronate once a month. In patients who had suffered from low-impact hip fracture, annual infusion of 5 milligrams zoledronic acid reduced risk of any fracture by 35%. Oral bisphosphonates are relatively poorly absorbed and must therefore be taken on an empty stomach with no food or drink to follow for the next 30 minutes. They are associated with inflammation of the esophagus, gingivitis, and therefore sometimes poorly tolerated, especially in patients with reflux esophagitis. Raloxifene is a selective estrogen receptor modulator. It acts on the estrogen receptors throughout the body in a selective manner. The serums act on the bone by slowing bone resorption by the osteoclast. It's also an anti-resorptive drug. Raloxifene is beneficial in patients who have risk of invasive breast cancer, a family history of breast carcinoma. Calcitonin actually is a weak drug. It acts through its effect on calcitonin receptors in bone. Actually, it's used as an analgesic effect in patients with acute fractures. Bone anabolic agents, teriparatide. Teriparatide is a recombinant parathyroid hormone, residues 1 to 34. It's an effective drug in treatment of osteoporosis. Actually, it's a second-line drug. It acts like parathyroid hormone, stimulate osteoblasts, thus increasing their activity. It's used mostly for patients with established osteoporosis who have already fractured, have particularly low bone mineral density or several risk factors for a fracture, or cannot tolerate oral bisphosphonates, given by daily injection with a maximum period of 24 months. Patients with previous radiation therapy or patched disease or young patients should avoid this medication due to the risk of sarcoma. Strontium ryanate, also another drug. It is less commonly used nowadays for treatment of osteoporosis because of its risk of development of venous thromboembolism. Rankle inhibitors, denosumab. Denosumab is a rewarding drug. It's used as second-line treatment in patients with osteoporosis through its effect on its monoclonal antibody. It mimics the activity of osteoprotein. It binds to rankle, thereby preventing rankle from interacting with rank and reducing its bone resorption. Some questions about osteoporosis. Osteoporosis is a silent condition that happens slowly over years. Of course, the answer is yes, true. The prevalence of osteoporosis increases with age. Of course, true. Modifiable risk factors for osteoporosis include vitamin deficiency, tobacco smoking, excess alcohol, malnutrition, all of the above. Definitely the answer is all of the above. Pathologies of steroid-induced osteoporosis include reduction in bone formation due to direct inhibitory effect on osteoblast, steroid-induced osteoblast and osteocyte apoptosis, and inhibition of intestinal calcium of absorption. The answer is all of the above. All of the following medications are anti-absorptive agents except, of course, parathyroid hormone. Vitamin D deficiency, another part of this, second part of this presentation. The objective is to understand the role of vitamin D in skeletal and extraskeletal tissues and to highlight the magnitude of the problem of vitamin D deficiency, to identify the complications and sequelae of deficiency of vitamin D, and to know how to prevent and treat this condition. Vitamin D, considered not a vitamin only, it's actually a hormone. It's actually fat-soluble steroid hormone that we get from sun exposure, food sources, and or supplementation. In human, vitamin D is unique because it can be ingested as cholecalciferol, vitamin D3, or ergocalciferol, vitamin D2, and because the body can also synthesize it from cholesterol when sun exposure is adequate. In the liver, vitamin D is converted to calcidiol, which is also known as 25-hydroxycholecalciferol or 25-hydroxyvitamin D, and which is the specific vitamin D metabolite that is measured in serum to determine a person's vitamin D status. Part of the calcidiol is converted by the kidneys to calcitriol, which is a biologically active form of vitamin D. Calcitriol circulates as a hormone in the blood, regulate the concentration of calcium and phosphate in the bloodstream, and promoting the healthy growth and remodeling of bone. Calcidiol is also converted to castriol outside the kidneys for other purposes, such as the proliferation, differentiation, and apoptosis of cells. Castriol also affects neuromuscular function and inflammation. This figure shows the synthesis of vitamin D, steps of the vitamin D in the body from sun exposure. The 7-dehydrocholesterol will convert to cholecalciferol, vitamin D. In the liver, it will convert to 25-hydroxyvitamin D3, and in kidney, the formation of active form of vitamin D, which is 125-hydroxyvitamin D3. Okay. Vitamin deficiency is more common in vegetarians, in dark-skinned people, patients with population with alcoholism, and people with liver or kidney disease. Vitamin deficiency is more common in people suffering from intestinal malabsorption. Actually, 1 in 7 adults worldwide have vitamin D deficiency. In one study, 42% of hospitalized patients under age 65 were reported to be vitamin D deficient. Vitamin D is more common in elderly people due to reduced absorption and transport or liver metabolism of vitamin D. There are only about 30,000 genes in our body. 3,000 of them are vitamin D dependent. That is one of the primary reasons it influences so many diseases, from cancer and autism to heart disease and rheumatoid arthritis. Link between vitamin D deficiency and cancer has been well tested and confirmed. Theories linking vitamin D to certain cancers have been tested and confirmed more than 200 biological studies. Here are just a few highlights into some of the most noteworthy findings. Some 600 cases of breast cancer could be prevented each year if vitamin D levels among populations worldwide were increased. Optimizing vitamin D levels can prevent at least 16 different types of cancer. A large-scale randomized placebo-controlled study on vitamin D and cancer showed that vitamin D can cut overall cancer risk by as much as 60%. Vitamin D has a protective effect against cancer in several ways, including increasing the self-destruction of mutated cells, reducing the spread and reproduction of cancer cells, causing cells to become differentiated, and reducing the growth of new blood vessels. Low blood levels of vitamin D associated with increased mortality. Of course, it causes skeletal effect, causes osteomalacia called rickets in children. Low serum vitamin D levels have been associated with falls and low bone mineral density, osteoporosis. Moderate to high doses may reduce cardiovascular disease risk, but this issue is a little bit questionable. Low levels of vitamin D are associated with multiple sclerosis. Pregnant women who take an adequate amount of vitamin D during gestation may experience positive immune effects due to the effect of vitamin D on immune function. It has been postulated to play a role in influenza, tuberculosis, HIV, and asthma. This is the main skeletal and extraskeletal effects of vitamin D deficiency. Osteomalacia and rickets. Osteomalacia is a defective mineralization of bone due to vitamin D deficiency, resistance to the effects of vitamin D, or due to hypophosphatemia. Osteomalacia is a syndrome in adults of defective bone mineralization, causes bone pain, increased bone fragility, and fractures. Rickets is the equivalent syndrome in children, characterized by enlargement of a growth plate and bone deformity. Disease, osteomalacia, is more prevalent in elderly people who have poor diet and limited sunlight exposure. The cause of osteomalacia is vitamin D deficiency, classical, or due to malabsorption, failure of vitamin D or of 125 synthesis due to chronic renal failure, or vitamin D resistant rickets type 1. Vitamin D receptor defects, we call it vitamin D resistant rickets type 2, or due to defects in phosphate and pyrophosphate metabolism, we call it hypophosphatemic rickets, or tumor-induced hypophosphatemic osteomalacia and hypophosphatasia, low alkaline phosphatase. Iatrogenic osteomalacia can be caused by bisphosphonate therapy, aluminum, and fluoride supplementation. The cause of vitamin D deficiency, two causes, either lack of sun exposure or dietary deficiency. The pathogenesis of vitamin D-induced osteomalacia due to low cholecalciferol, lead to low 25 by liver and low 125 by kidney, lead to low calcium absorption and low serum calcium, increase in the parathyroid level. This will lead to phosphate wasting and increased bone resorption and lead to progressive bone demineralization, osteomalacia. Clinical features of osteomalacia include asymptomatic or present with fractures if mild. It is a cause of muscle pain and bone pain, malaise, proximal muscle weakness involving shoulder and pelvic girdle, bone and muscle tenderness. The clinical features of rickets include delayed development, muscle hypotonia, worsening of frontal and parietal bones, delayed anterior frontal closure, enlargement of the epiphysis at the lower end of the radius, and swelling of the rib costochondral junction, what we call rickety rosary. Common symptoms in young children due to vitamin D deficiency are failure of normal development of bones, leading to fragility and deformity. Children with rickets can have various skeletal deformities like knock knee, bow leg, pigeon chest, abnormal curvatures in the spine, short limbs, and an overall stunted growth, like in this picture. Investigations include raised serum alkaline phosphatase, low 25-hydroxyvitamin D, raised parathyroid hormone, and low or normal calcium and phosphate in blood, the serum. X-rays are normal, or there may be a focal radiolucent areas. We call it pseudo-fractures or loser zones. In advanced disease, osteopenia, vertebral crush fractures also can present. In children, thickening and widening of the physical plate. We are need for X-ray of the wrist for diagnosis of rickets. This is the pseudo-fractures or loser zone in the ribs and in the femur. The management of vitamin deficiency or osteomalacia is the use of ibuprofene in a dose of 250 to 1,000 micrograms daily for 3 to 4 months, with a maintenance dose of vitamin D reduced to 10 to 20 micrograms daily. This is the dietary reference intakes of vitamin D according to age. The food which are rich in vitamin D. Vitamin D supplement is important in some conditions. Question 1, osteomalacia is prevalent in elderly people who have a poor diet and limited sunlight exposure. Of course, this is a true statement. All of the following are clinical features of osteomalacia except muscle pain, bone pain, malaise, distal muscle weakness. Of course, this is the wrong answer. Distal muscle weakness affects the proximal muscle mainly. The laboratory findings of osteomalacia include all of the following except raised serum alkaline phosphatase, of course, true. Low 25-hydroxyvitamin D also is true. Low parathyroid hormone, this is wrong. The parathyroid hormone will increase. Low or normal serum calcium and phosphate, both are true. And thanks for listening.